Good afternoon. This is Jim Rosemary from the Department of Medicaid. Thank you for attending the webinar in the Incident Management Rule, Rule 5160-4405. Our intended audience for today are the care management entities and recovery management entities, and also PCG may be online as well. So without any further ado, we're going to go ahead and get started. So the purpose of these rules is to ensure the health and welfare of individuals receiving waiver services and SRS, Specialized Recovery Services as well. The rule applies to the Department of Aging administered programs, passport and assisted living Medicaid waivers, as well as the ODM administered programs, the Ohio Home Care and My Care Ohio waivers, and specialized recovery services. With these rules, we expect to gain a more consistent experience across programs for both providers and individuals. And we want to ensure that individuals are appropriately having incidents reported and investigated or otherwise addressed. All this will help us ensure compliance with the Centers for Medicaid and Medicare Services program requirements. These new rules will be able to help us to track and trend incidences across waivers and across care management entities. I will say that the Department of Aging will present separately to the passport administrative agencies with regard to passport and assisted living Medicaid waivers. Okay, so with this, the new rules, we will have the same set of incidents being reported and addressed regardless of the program the person is on. And this will allow us to better focus resources for more critical incidents that require more resources while still retaining the ability to identify issues before they turn into something more serious. The status of the incident rules and the IMS, the Incident Management System. The rule has been filed with an effective date of July 1st of 2019, coming right up. The Joint Committee on Agency Rule Review hearing is set for tomorrow. And in Section D of the rules, a single incident management system that is being built to be able to receive reports of incidents. It is on track for July 1st as well. Training on how to use the IMS is forthcoming in a different webinar. ODM programs will also report provider occurrences in the incident management system that are not defined as an incident per this rule, but they'll still be reported through the IMS. And ODA, their programs will continue to report provider occurrences through their internal processes as well. In addition to being able to report incidences, the investigative entity will also be able to document their work in the IMS, and as well as provider oversight staff will be able to review their provider occurrences for ODM approved providers as well. Just a definition here for incident, just to kind of set the stage. This is just copy and pasted from the rule. An incident means an alleged, suspected, or actual event that is not consistent with the routine care of and or service delivery to an individual. This is no change from the current ODM rule. And I will add a couple other definitions just because I use them a lot throughout the presentation. Investigative entity that today, right now, is currently PCG for the ODM waivers. So this will be the entity that's under contract with Department of Medicaid to investigate critical incidents come July 1st. And for the Department of Aging waivers, I believe it's the AAAs who will do that. A case management entity or CM entity, that's the care management entity that's delegated by ODM to provide care management and related functions for the waivers. So we're talking about like the My Care Ohio plans, CareStar, CareSource, the passport administrative agencies. So just to give you overall foundation, this is just an overview of the type of incidents in the new rule. List of critical incidents are listed here: abuse, neglect, exploitation, misappropriation, unexplained death, health and welfare risk due to 4 subcomponents, law enforcement intervention, health and welfare is an immediate and serious jeopardy, unexpected crisis, and the individual can't be located. And then the 7th critical incident is prescribed medication issues that involve either provider error or individual's misuse resulting in emergency EMS response or emergency room visit or hospitalization, as well as repeated refusal to take prescribed meds resulting in EMS response, ER, or hospitalization. With critical incidences, those will get full in-depth investigation, which is done by the investigative entity. It includes things like a review of documentation, interviews, and it results in determination of whether or not the incident was substantiated. And a prevention plan would be required when they are substantiated. The reportable incidents, those are death other than unexplained, individual or family behavior, action or inaction that results in a creation or change to a health safety action plan. The 3rd one is health and welfare risk due to loss of a caregiver. And there's prescribed medication issues that involve misuse or repeated refusal, where these do not result in a hospitalization, emergency room visit, or EMS response. The 5th one is hospitalization when it results in a change to the person-centered service plan. And then the last one is eviction from place of residence. The reportable incidents, those will be addressed by the care manager. They'll be entered into the incident management system to allow for identification of trends and patterns. And there will be more on these later. I know I just went through very quickly. We're going to take them later one by one. Okay. Reporter responsibility. I'm just going to go through some of these other foundational things before we get into the incident types themselves. Reporter responsibilities. This is essentially section paragraph G in the new rule. ODM, ODA, their designees, all service providers are required to report all incidents. And their responsibility will be to take action to ensure the health and welfare of the individual. Any incident needs to be reported to the care management entities. And those time frames for doing so will vary among ODA and ODM. And for Specialized Recovery Services Program, if the individual's on MyCare, the recovery manager will report the incident to the MyCare care manager. And providers, if they have a supervisor, they need to inform their supervisors. And additionally, the care management entities for ODM need to report provider occurrences into the IMS. And we'll have more on this later in the presentation. And so the report, what is actually gets reported to the care management entity are the relevant facts, the description of the incident, the type, date, and location of the incident, names and contact information of all persons involved, and any actions that were taken to ensure the individual's health and welfare. The time frames for the reporting incidents are the same as far as the ODM side is concerned as they currently are today. Okay, a little bit about the roles for the care management, recovery management entities. So upon discovery of an incident, the case management or recovery manager entity will ensure the health and welfare of the individual, and as applicable to the nature of the incident, notify any regulatory oversight or advocacy agencies. I will add, because we already have gotten the question about the primary care physician. That does continue to be in here as somebody to be notified, but it's only as applicable to the nature of the incident. I've heard the comments about it. Seems like in the current rule, every incident, regardless, has to be reported as a primary care physician, and we just made it more clear that it's applicable to the nature of the incident. The third thing is to enter the incident into the incident management system. And the IMS will automatically inform the state of issues identified in the rule, and those are of any critical incident, any public media story, or any time an employee of the care management or recovery management entity or the investigative entity is the alleged person responsible. And so I would also point out that public media story does not mean just an obituary of a death. It does not mean just something that you saw on social media like Facebook. A real life example is an individual enrolled on one of the waivers shot his brother, who was a respected minister in the community. That gained a public media story. That's the kind of thing we're talking about. And the time frames for ODM programs remain the same as they currently are. A little bit more on the roles and responsibility for care management, recovery management entities is that basic care management activities apply. You will determine the factors leading to any incident. In other words, what happened, what caused it, and you'll establish measures to prevent the incident from happening in the future. This doesn't mean that you're doing an investigation. It just means that something happened, you find out what caused it, and then you try to put anything in place that's necessary to prevent it. For critical incidents, we would point out that the care management entity is expected to work cooperatively with the investigative entity, for example, providing the requested documentations, whatever it is. And we will have more on the care management responsibilities, particularly regarding reportable incidents later in the presentation. Okay. Last piece before we get into the actual incidents. This is just a display of the pathways for the incident management system. So what will happen is once an incident is entered into the system, it will automatically assign a pathway based on the type of an issue. Critical incidents, for example, per the rule, those will end up with the investigative entity queue, who will go into the IMS and do a full investigation, document all their work and their outcomes. And if in the end a provider is an alleged person responsible and it's a substantiated incident, you see the dashed line also refers it over to the provider compliance area, so that the waiver provider oversight contractor can take it from there. Reportable incidents, those are addressed at the care management level, but here again, and so the investigative entity will not be investigating those, but we do want to track and trend them so they get entered into the system. Their outcomes get entered in the system. And whenever the provider is likely to have done something wrong, here again, it will be referred over to provider compliance issues. And so also, if the investigative entity for Department of Medicaid discovers an additional incident during the course of the investigation, they can go ahead and also enter the incident, and the system will auto-inform the care management entity. For example, they may be investigating abuse, and then they also find that there's a theft or misappropriation that also occurred. Okay, so now we'll go through the incidents one by one.
Do you want people to enter questions in the chat box? We can get to them
we'll get,
as we can.
Yeah, I think if it's okay, I'd like to take them at the end because the questions may or may not be answered during the course.
We'll have a record.
Okay, thank you. Okay, so abuse. What I've actually done here, we've just copy and pasted exactly from the rule, and then we've given examples. So abuse is the injury, confinement, control, intimidation, or punishment of an individual, including self-abuse, that has resulted in physical harm, pain, fear, or anguish, or mental anguish. And it also includes physical, emotional, verbal, and or sexual abuse, and the use of unauthorized restraint, seclusion, or restrictive intervention, as well as the use of authorized restraint, seclusion, or restrictive intervention that results or could be expected or reasonably expected to result in harm, pain, fear, mental anguish to the individual. So in the incident management system, what you'll see are these subcomponents broken out. So it actually will become very, very clear and easy to indicate the specific kind of abuse or abuses that you are reporting. So a couple of examples. A neighbor punched the individual. That would be physical abuse. Verbal abuse could be a son yelled angrily at the individual, if you can't walk by yourself, you're worthless and you should be put out to die. The individual is offended and felt berated. I know it's kind of a harsh example, but these abuses are a little bit harsh. A suicide attempt. We believe that self-abuse was being included in current incidences, but and so we're memorializing it in the new rule. But regardless, whether it was or not, we want to make sure it is. So the new rule does include self-abuse. Okay, neglect. Neglect, when there's a duty to do so, failing to provide an individual with any treatment, care, goods, or services necessary to maintain the health and welfare of the individual, here again, including self-neglect. A couple of examples. Individuals found in bed, lying in feces, unchanged because the provider did not show. Or individual refuses services, they're found in bed, lying in feces. That could be an example of self-neglect. Exploitation. This is actually no change from the current ODM rule. It's the unlawful or improper act of using an individual or individual's resources for monetary or personal benefit, profit, or gain. Couple of examples: individual is scammed into signing over their property, or a person who's doesn't have authority to use the individual's vehicle uses their vehicle for their personal use. Misappropriation, another one. There's no change at all from the current ODM rules. Depriving, defrauding, or otherwise obtaining the money, real or personal property, including prescribed medication, of an individual by any means prohibited by law. For example, individual's jewelry, money was stolen from the individual's dresser. Unexplained death. This one is no change. It's just relabeled unexplained as opposed to suspicious. It's an unnatural or accidental death that could not reasonably have been expected, and the circumstances or cause of the death are not related to any known medical condition of the individual, including inadequate oversight of prescribed meds or misuse of prescribed meds. A couple easy examples: individuals a victim of homicide, or they died in a house fire. Okay, a couple more. The sixth critical incident, health and welfare of the individuals at risk due to any of the four following subcomponents. Activities involving law enforcement intervention, or the individual's health and welfare is in immediate and serious jeopardy, or an unexpected crisis in the individual's family or environment, resulting in the individual in the inability to ensure the individual's health and welfare in his or her residence, or the individual cannot be located. So some examples of law enforcement intervention: the police raided the individual's home, shut it down due to a meth lab being there, and the home was deemed unsafe. Another example, providers transporting the individual, left the individual in the car for 2 hours in 90-degree temperature while the aide overdosed in a friend's house and died. Immediate and serious jeopardy. That's actually a real case. Example of an unexpected crisis, the individual's environment, the home was hit by a flood or a tornado or a fire. The individual cannot return to the home. And another last example, after several attempts to locate the individual, their whereabouts are still unknown. So I do also want to point out, though, that through the rules development process, we are aware of some questions that people have about B and C, the immediate and serious jeopardy, and the unexpected crisis. And so we just want to point out the focus of unexpected crisis is on the surroundings of the individual, something that happens unexpectedly in the person's family or environment, such as a flood or fire or tornado. Whereas the in health and welfare of the individual being in immediate and serious jeopardy, really the intended focus here is more specifically on the individual. Really, you just choose the one that's most applicable, and it's really not generally going to be necessary at all to assign both. And so while we encourage people to check all incidents that apply to a situation, I do want to note that the intent is not to tack on unexpected crisis or health and welfare is in immediate and serious jeopardy to every other incident. You could almost just say those two could apply to everything, and that's just really not the intention. These two are really more for something bad happens that is critical, and it just doesn't fit into any other category. I can tell you through the rules process, these were sort of a catch-all where people were, there was a lot of concern that maybe we're going to miss something. And so it just kind of, how rules processes work, ended up being, okay, if you can't fit them in any other more applicable incident type, we have this when something really bad happens. Okay, the last critical incident is any of the following prescribed medication issues. Whenever there's a provider error with a medication issue, the individual's misuse of the medication resulting in EMS response or emergency room visit or hospitalization, or the individual's repeated refusal to take a prescribed medication resulting in EMS response, emergency room visit, or hospitalization. And we will see these two repeated under the reportable incidents. The difference between critical and reportable is whether or not it resulted in the EMS, ER, or hospitalization. But we'll see that later. So a couple of examples: the provider gave the individual wrong dose of prescription Nexium. That would be provider error. Individual accidentally overdosed and was in bad shape, so the daughter called 911. The individual was taken to the emergency room. That would be a misuse. Individual repeatedly refused to take insulin, resulting in the son called 911. The individual was taken to the emergency room. So now we'll move to the 6 reportable incidents, one by one. First one we have is death other than unexplained death described in paragraph E5 of this rule. A clear example we have is individuals on hospice for a month and passed as anticipated. There's nothing unexpected, unexplained, or strange about the circumstances surrounding the death. And this is no change from the current ODM rule. Next one is the individual or family behavior, action, or inaction resulting in the creation of or an adjustment to a health safety action plan. An example here is while the provider is at the home, the individual is using heroin. As a result, a health and safety action plan was created. Another example, there's an existing health safety action plan, and a family member continues using offensive language with the provider. So the health safety action plan had to be adjusted. Loss of caregiver. The health and welfare of the individual is at risk due to the loss of an individual's caregiver. Example we came up with is individual's live-in son was providing daily care with us and assistance with medication. The son suddenly dies, placing the individual's health and welfare at risk. And for example, the backup plan was either maybe it was refused or it was insufficient to meet the individual's immediate needs. So we want to point out here that not every loss of a caregiver automatically places the individual's health and welfare at risk. You may have the example of a husband who's giving baths to the individual, suddenly dies, but an agency personal care aid is promptly put into place to furnish the service. So just not every incident of a loss of a caregiver will rise to this level. Prescribed medication issues. So any of the following prescribed medication issues would be a reportable incident where the individual's misuse but does not result in an EMS response, ER visit, or hospitalization, or the repeated refusal to take prescribed medications but does not result in an EMS response, ER, or hospitalization. A couple of examples we have. The individual takes 2 prescribed Nexium rather than 1 as prescribed at dinner time. The person experienced no ill or adverse effects, no EMS, ER, or hospitalization, but that would be an example of misuse. Individual repeatedly refused to take prescribed Zoloft, but otherwise is not experiencing any ill or adverse effects. The key here again, no EMS or response, ER, or hospitalization, but the person's refusing. So the idea behind these is we do want to track these things. We do want to know that they happen, and so that we can track and trend and give feedback to the care management entities if we see trends or patterns that they may need to take a closer look into. Okay, a couple more. Hospitalization that results in adjustment to the person-centered service plan. An example here is the individual is hospitalized for acute pancreatitis and had surgery. She now needs help with bathing that she didn't need before. And we would point out as well that the incident, the hospitalization needs to be the incident or hospitalization has to be the cause of the service plan change. So not just any change to a service plan. That's kind of the key here. And as far as when it is considered, because we've been hearing, okay, you don't know that there's going to be a change to a service plan until sometime later. Well, the incident should be reported at the time you discover that the creation or adjustment of a service plan is needed. That's different than what they had before. It's at that point when it's considered to be a reportable incident, because you're right. The folks who brought this up, you don't know it until you know it, but at the time you decide, okay, this hospitalization is resulting in a service plan adjustment, that's when you discover the incident and need to report the incident. The last reportable incident, eviction from place of residence. Pretty self-explanatory. The individual's in an assisted living facility, was not paying his room and board, and was evicted. Or the individual in an apartment had too many pets and was evicted. Again, these are things that we want to track and trend for patterns, so they are to be handled by the care management entities, addressed, but we want to track and trend in the incident management system what happened. Okay. So now I'm going to go on, before we start taking questions, I'm going to go on to the incident management system provider compliance issues. This is the same chart that we saw before, but we're going to focus a little bit on the provider compliance, provider occurrences rather. So although provider occurrences are not in the new incident rule, they still remain in Ohio Administrative Code rules, 5160, 4506, and 4510 for the ODM rules. Provider occurrences are required to be documented in the new incident management system for ODM programs. And so while we're not going to go through each of these, the point here is it's important for you to take these back and familiarize yourself with this list. These will essentially be the pick list of provider occurrences that you can report in the incident management system. So anytime you see something like this, we want to make sure that you report it to the incident management system, and it will follow the pathway then that where it'll reach the provider oversight contractor, and will be able to be dealt with through their processes. We are recording this webinar, so you will have this list. You'll be given this list, but even when you go into the incident management system, you'll see these things in here, so they need to be reported. Okay. Just a note on prevention plan changes. So prevention plans will no longer be required, will no longer require the investigative entity approval. You'll still go in and enter your prevention plans into the incident management system. It's just that they won't have to be approved by the investigative entity. And so with that, ODM will monitor prevention plans and provide feedback to case management entities. So it's not that they're going ignored, they're being captured in the system, and we will be doing essentially most likely record reviews and make sure that the prevention plans are good. And so
hi, can somebody respond and let us know if you're still able to hear us and also see us? We just had an alert come up that we may be losing connectivity.
Okay, we're good. Keep going.
Okay, thank you for that. So the last point about prevention plans is that they are expected for all substantiated critical incidents. Okay. Just a few more slides here before we start taking questions. Reportable incidents. I had mentioned that we were going to get back to this as well. So reportable incidents, it's kind of a new concept, and we want to make sure that understand that whenever one of those 6 reportable incidents happens, they are to be addressed by the care management entity or recovery management entity. They're not investigated by the investigative entity, but as part of your normal case management processes, we expect that you're finding out what was the cause, take care of it, and do what you need to do to prevent it from happening again. You'll be reporting the incident in the incident management system, as well as the outcome. So we want to be able to see, okay, these are getting addressed. And as well as you'll enter into the incident management system what was done to resolve the issue. Now, the time frames are not in the rule, but we will be establishing time frames to resolve a reportable incident in a supplemental guide. And at this point, we believe it's going to be 30 calendar days. And so the MyCare Ohio plans are no longer required to send findings of investigation because you're not doing investigation. It's the investigative entity that investigates. The last couple of slides are really just a comparison of the current rule to the new rule. This is just kind of shows how things aren't getting lost, and we wanted to be able to give you an idea of crosswalk between the two. So, for example, abuse in the current rule is still abuse in the new rule. Neglect is the same, exploitation, misappropriation. Suspicious death just got renamed to unexplained death. Non-suspicious death is similarly a death other than one that is unexplained. Now, hospitalization or emergency room visit, that is captured in a new system, but it's a little bit more focused to where not every hospitalization is called for an incident, but rather when it's resulting in a change to the person-centered service plan. So that's a little bit of a new twist. Unauthorized use of restraint, seclusion, or restrictive intervention, those are all captured under in subcategories of abuse. Whether it's unauthorized or authorized, it's captured. Unexpected crisis, it's still there, it's just moved into a subcomponent under the health and welfare risk. Due to those 4 subcomponents, it remains there. It's just one moved under that category. Inappropriate service delivery. That's captured under medication issues, provider errors, but I would point out that all provider occurrences, that list that we showed you before, even if it's not an incident per this rule, are still going to be captured. The care management entities still need to report those in the provider occurrences in the incident management system.
I'm still learning this.
Okay. And the last slide that I have, you are all learning this together. The last slide that I have, just because it wouldn't fit on the previous slide, is the health and welfare risk due to, in the current rule, we have law enforcement involvement, the individual cannot be located, misuse of medications, and illegal drug use. I had to do some fancy coloring to crosswalk it to where it is in the new rule. But under the new rule, we also have health and welfare risk due to law enforcement intervention. The individual cannot be located. As far as misuse of medication, that just kind of got pulled out to be a little bit more separated, to be issues of prescribed medication issues, more of a standalone, rather than just under the health and welfare risk. So we still have that under misuse is still there. It's just whether it's a critical incident when it results in an EMS or ER visit or hospitalization, or whether it was not resulting, but in either case, it's still being captured. And what we did with the illegal drug use is it pulled out to its own standalone, but a little bit different. Again, a little bit more focused, kind of like the hospitalizations, where this would be captured under individual or family behavior action or inaction. That results in a change to health safety action plans, creation of or change to one. That's how we tried to focus a little bit more. And there are two new categories, though. Health and welfare risk due to loss of a caregiver, as well as eviction from place of residence. And those two did not previously exist in the ODM rules. Okay, so I am going to we'll start taking questions.
Who is responsible for investigating the provider issues? The provider oversight contractors will be, so once you enter in that provider occurrence into the IMS, it will be investigated by the provider oversight contractor. Okay. If the change to a person-centered service plan is temporary, say, for example, additional meals for 1 week, is that still an incident?
Well, and part of this one, it is the result of this is a result of a hospitalization. So if there was not a hospitalization that resulted in the service plan, we don't want every change to a service plan to be reported. Yeah. And anybody in the room correct me too if I'm wrong. I've got support here.
So we have a question here. Does the creation of a health and safety action plan result in the need for an incident? And the answer is yes. Okay, for hospitals, if a person was on dialysis and receives a kidney transplant, do I need to complete an incident report?
Well, the question is, did the hospitalization result in a change to their service plan?
And that would be determined like at discharge.
Right.
So it wouldn't really necessarily be that the person had a kidney transplant. It would be the changes to their services upon discharge.
That's right. The reason for the hospitalization doesn't matter. It's what happened with the service.
Okay. We have a couple questions about the slides, how the slides will be shared.
We will share them. I don't.
We can send them out to the main managed care plan mailboxes, to case management agencies, and we can make sure they get to PCG. So if you're listening and you're not through one of those, send us a message so that we can capture that. Okay. They are coming in quickly. Okay, is self-abuse new? Can you help us tell the difference between self-abuse and self-neglect?
Okay, so I'm going to just go back to our slides because I believe we have some examples. Sorry, everyone, I'm going very quickly through these. So suicide attempt, for example, could be a self-abuse. I would not say that that is neglecting anything. You are abusing yourself by attempting the suicide, and most likely that would certainly result in some kind of mental anguish or pain or something. So I think that's where that one falls. Self-neglect is like failing to provide the treatment, care, goods for yourself. So our example we came up with is individual refuses services. So that's really not abusing yourself, not trying to cut yourself, kill yourself, what have you. Our example is try to saying you're neglecting, you're refusing services, and therefore something bad is happening with that.
We have a question. Do we still need to report provider issues and occurrences quarterly since we are now recording in the IMS?
Oh, can you repeat that?
Do we still need to report provider issues and occurrences quarterly since we are now recording in the IMS?
I don't
Do we know what entity that's coming from?
We're thinking not. We're thinking that,
Yeah.
that the IMS will satisfy that. Right, Wayne?
Yes.
Okay.
Okay. Not sure if PCG is still involved in the Big Five investigations. So instead of what we used to call the Big Five, we now have the critical incidents, and the provider oversight contractor will be investigating the critical incidents. If we discontinue a health and safety action plan, would that warrant an incident? The answer is no. Okay, for the category of hospitalization resulting in adjustment to the person-centered services plan, does this include just changes with waiver services? If they have to go to a NIF or rehab following the hospitalization, would that be included?
I guess it goes back to changing the service plan. So if the change, and again, this might not be known until after that NIF placement is completed, how they need to change the service plan for, as a result of that hospitalization. And remember, we always go back onto when that decision was made, that discovery was made. So it doesn't mean you have to report as soon as the hospitalization, but to see what the results of the hospitalization are.
We've had a couple of requests to include all the questions and answers when we share this presentation. And we might not have all the questions and answers when we share this actual presentation, but it is our intent to get a frequently asked questions document together shortly and shared with all of you. Okay, member refused to take medications and member has multiple ER visits associated with what medication is treating. Is that reportable?
Go back to your slides. Is that a...
Yeah. It's about refusal to take medications, right?
Mm-hmm.
Okay. So if the individual, what is the question about it again?
So the member has refused to take medications and the member has multiple ER visits associated with what the medication is treating. Is that reportable?
I would say yes.
It's critical.
Critical, because
so again, it's a terminology issue, right? Now
Yeah,
we have the term
critical.
reportable versus critical, but yes, you are reporting it.
Thank you.
Yes, and it's critical because that key there is that multiple ER visits associated. If there were no ER visits, then it would be just a reportable.
So in either case, it gets its way into the incident management system.
Okay, we got a question. If you're making a change to the service plan due to a hospitalization, is that only an incident if it's a long-term change or if it's any change or a temporary change and it's any change?
It's any change related to that specific hospitalization.
If they do a health and safety action plan for out of state temporarily, would that be an incident?
This is probably a case management agency from Ohio Home Care Waiver, SRS, I'm assuming. I will refer back to their case management guide to see if that is still required to do a AR, which is currently known as an AR or an HSAP based upon out of town or travel.
All right. We have several more questions. I'm just trying to catalog them here. Okay, do the provider occurrences pertain to SRS, or would any provider occurrences be against the RMA or RM, since we are the provider of services? Our area does not have IPS-SE or PRS, so recovery management is the only service that we have in our area.
So you could have provider occurrences, yes, but that is true that the RM could be, but they could also be reporting. There could be somebody on SRS who's receiving other services that they could be reporting for a provider occurrence. Is that correct, Wayne? Yeah. So, and obviously themselves as well, because they are considered a provider in the SRS world.
With the IMS, in the reportable incidents, I have been asked to complete the resolution. Would that be completed after some kind of investigation, or is it expected to complete the resolution at the time the incident is entered?
So I think they're referring to the IMS system. This is probably a person who is tested. So yes, you were supposed to complete the resolution, but at the time that you have a resolution. So you can submit the incident in the IMS system without completing the resolution. And we will talk about timeframes related to that in the system. So the system will give you a time frame in order to complete the resolution so that the incident is closed. And a formal investigation is not done, but it is expected that the case management entity look into the situation and come up with an appropriate resolution based upon whatever was reported.
To report the provider occurrences, can we do this without checking critical incident or reportable incident in the IMS? And this is regarding the system.
Yes.
Yes. There's a provider occurrences portion, like a box.
Yeah, and it's, the only people that won't see the provider occurrences, and I don't believe this is our audience, is the ODA waivers. But all the ODM waivers should be able to see all the provider occurrences and pick them.
Are we still reporting falls resulting in ER visits?
So again, we're going to go back to your hospitalization one, and it's a result in the change in the service in the person-centered services plan. So that could possibly happen, or it could not. I can't answer that for a blanket statement, but it depends on what's the result of that ER visit.
Okay, so provider occurrences can be for any paid provider, not only the waiver or SRS provider, like a BH provider or PCP or maybe state plan providers. They just want to make sure they understand correctly.
Yes.
And the answer is yes. Okay, question, who is the provider oversight contractor? Who is the investigative entity?
Today, currently it's PCG. We don't know for sure who it's going to be come July 1st.
Ohio Home Care Waiver, can you briefly re-explain the case management process for reportable incidents?
Want to go back to your slide?
So yeah, so for reportable incidents, the care management entity will enter it into the IMS. They will do whatever they need to do to take care of that individual. It's not investigated by a third party or the investigative entity, but you will find out what caused the problem. You'll make sure that their health and welfare is addressed, and you'll report the outcome and what was done to resolve the issue into the IMS. So I think, and so basically, and taking any measures to prevent the incident from happening again.
Yeah, I mean, truthfully, you're doing exactly what you probably should do for a critical incident. The difference is the investigative entity isn't coming back and providing the case manager with the causes and contributing factors. The case manager is doing that assessment on their own, and then they're developing and I have quotation marks, which would be a prevention plan or a resolution to that particular incident. And up here, we do have the 30 calendar days. So what we would require is that resolution is placed within 30 calendar days after the incident is submitted.
And then this might speak to how the system's going to work. This question is, I don't understand if we're not investigating a critical incident and there is an update or a decision regarding the case, how are we going to know the updates to share with the case management staff?
Oh, very good. So that's a great question. The way it works is if there's a concern, well, there's a couple of ways to answer this question. If during the course of the investigation, the investigator needs to ask a question to whomever submitted the incident or needs some additional information, within the system, they can do a task and notify that person in order to, tell them what they need and give them some time frames to respond. Once an investigation is completed on the investigator's end and say it is substantiated, a prevention plan is required. The case management entity will get notified that that case went over to or is in the prevention plan needed status, and the case manager will be notified of that and can go in there and make those updates. And I believe we are working on functionality that when the case is closed, so say it was unsubstantiated and so there was no other need for the case manager, that the case manager will be notified of those closed incidents as well.
And you will all get more training on the system, which will, I think, sort of help see how this rule can be.
Yeah, how it's going to work.
Yeah.
And it's probably from a person who's testing now, and we haven't got the second phase of testing actually starts this evening, tomorrow, where they'll see those notifications come back to them saying, hey, we need a prevention plan, or, you know, there's a question about this particular case.
I'm going to assume this person is from a plan. Just to verify, we will not be submitting monthly reports, as we will not be, just as we will not be submitting quarterly reports.
Yeah, we should be able to get everything from incident management system that we need in those reports. So we're not necessarily going to end them right away, but I think July 1st probably we'll have what we need, and we will give you formal communication about those reports.
And you should be able to run your own reports too, in the system, which will be nice.
Right, that won't be effective July 1 as far as running reports, but that's something that will probably happen within the first couple of months of the system going live.
Does ODM substantiate cases, or are compliance QI staff doing it?
The investigative entity will substantiate case based on their investigation.
So I'm assuming this is related to the criticals. Yeah, it will go to the investigation process. They will substantiate or unsubstantiate, and then the case management entity will be notified.
If a member falls and goes to the emergency room and there is no change to the service plan, but was not using appropriate DME, incident report due to neglect. That's a question. Should they file an incident report for neglect?
So I have to go back to, there's so many circumstances that can play in that particular case for that individual. I mean, you know, and the neglect is usually about the intent. So I would really probably have to dig a little deeper in order to answer that question. On the face, I say, no, there doesn't need to be a neglect filed. But again, there might be other circumstances related to this particular individual.
Is the case management contractor investigating critical incidents?
No, it sounds like a confusion of terms. We have a investigative entity contractor who investigates critical incidents. Case management entity are like the MyCare Ohio plans, CareStar, CareSource, who are doing case management. So only the investigative entity, which today is PCG for Ohio Home Care and MyCare waivers and SRS. But whoever ODM contracts with to do investigations will be the one investigating.
If a provider or agency is involved in a critical incident and it is unsubstantiated, will you be notifying the provider or agency of the unsubstantiated outcome?
I think we need a little bit more information. So I guess the course of the investigation is going to take place. In the beginning, as soon as it's reported, it's going to be notified that a provider, a case management agency was an alleged violator. But then all the information will be located within the incident itself as a result of the investigation.
They're asking if the provider themselves would be notified if a incident's reported and it's unsubstantiated.
Yeah.
Yeah. I think we let the reporter know that it's unsubstantiated, but we probably would not tell the entity.
Yeah. Okay. If you have more you want to ask about that, type into the box. Will any incident reports be entered into the CMA documenting system, now known as CSCMS version 2?
No.
No. Come July 1, all incidents for CareStar, and this is Ohio Home Care waivers, or what I'm assuming they're referring to, will go into this IMS system.
And why don't you talk about the date
Yeah, so, and we haven't talked about the transition plan, so I understand this question definitely. But, as of July 1, any incident discovered, so even if the incident occurred on June 30th, but the case manager doesn't discover till July 1, those incidents go into the IMS system. So, but if something happens and the case manager is aware on June 30th, they need to report that into their current system, which is, the CareStar information system.
And then the provider oversight contractor will work in both systems.
Yep, correct. They will have access still until all those cases are resolved.
If the case manager is adding a skilled Medicaid or Medicare paid service or hospice to the service plan following an individual's hospitalization, would that be considered an incident?
I would say if they, they're changing the service based on a hospitalization.
Because of that organization.
When you say the case management entity will be notified of a need for additional information, does that go straight to the case manager who entered the report, or does it go to the clinical managers and is cascaded down?
No, it goes to whomever. The way the system is set up today, it goes to whomever is assigned, whoever submitted that case. It will go to them. However, as the clinical manager, they have access to all the incidents in that system, so that they can see if any task has been assigned or sent to various case managers.
This is a question. Incident alerts will now be what is considered a critical versus reportable.
So I think this, the proposed rule doesn't refer to alerts in the way we think of them today. So there's no such thing as an alert in the future. However, those things that need to be that ODM needs to be notified, which do include critical media, as well as if a provider oversight contractor or a case management contractor was alleged violator, that will happen within the system itself. So there won't need, as of today, we do separate emails to notify ODM. That will not need to occur come July 1 within the IMS system. Those notifications will happen as long as the appropriate boxes are clicked and the appropriate incidents are checked.
Do the case managers have to send out a letter stating substantiated unreportable incidents?
No, so I don't believe that in the rule we refer to reportables as substantiated or unsubstantiated. It's just verified. But we would expect that conversation would happen with the individual about the results of that, and that's where the resolution comes in.
How are you going to prevent duplicates?
So I guess we're talking about the IMS system. And those are things that come up with when we look at reporting and how we do monitoring of the system itself. And we'll probably discuss that in the future with the entities as they utilize the system.
Some of these are repeats, so I just need a minute to read through. Is a prevention plan required for reportable incidents?
So not a formal prevention plan, as we discussed with the criticals, are required for the reportables, but there is a resolution that needs to be added. And I would say that is in the same vein as a prevention plan. So yes, it's just different terminology, but the context of the information should be the same.
What are the expectations for the plans, the incident management teams, when it comes to investigations if they are no longer required for reportable incidents?
Well, so if it's a critical incident, the investigative entity will do that work. If it's a reportable incident, as we mentioned, you'll need to enter the incident into the IMS. You'll need to indicate what was done, what the outcome is, and you will still need to do all your case management work. We're going to monitor, ODM is going to monitor reportable incidents. We're going to see if there's trends and patterns that arise. So if we, for example, see the same thing happening over and over and over again, we are going to monitor for that, and then we would come back to the case management entity and say, hey, we're aware of this, and bring it to your attention so that it can be addressed. So it's just not formalized as a formal investigation with all the notifications as a critical incident.
If a critical incident is substantiated, a prevention plan is required. Does that mean that we wait for the substantiation before we do a prevention plan?
Yes, the reason why is because the investigation should identify the causes and contributing factors, which should be used in order to develop the prevention plan. Now, that doesn't mean interventions don't need to stop, so if there's anything the case manager sees fit that needs to be done based upon what happened with that individual, we want to encourage them to document that and to do that, in their as a case manager. But so they may come to the prevention plan and have implemented some of those things that were identified through the investigation. So we still want immediate health and safety to be taken care of, and we still want interventions to take place even during the course of an investigation.
What if there is not a provider oversight contractor with a HHA? So I think when we use the term provider oversight contractor, we're talking about our relationship that we have currently with PCG and that they investigate the critical incidents, not like a provider oversight contractor with any specific agency. If that does not answer your question, just go ahead and type in again. Will we still need to send daily alerts once we are using the IMS? And I think we covered that. No, the answer is no, you will not need to send daily alerts. The system will notify us on things we need to know about. Would the incident related to change in services due to a hospitalization include all service changes, even in the event that the management agency is not authorizing the services?
So I guess they're talking about like non-waiver services, maybe?
Maybe.
I don't know, but I would say anything related to that hospitalization, if that person needed increased hours, a referral made or anything related to that hospitalization. And Jim, definitely correct me if I'm wrong, if that's the intent of the incident rule, that should be, submitted as an incident.
Misappropriation for a theft over $500 would be considered an alert. This new rule does not have a minimum dollar amount. Are all thefts a critical incident now?
Yes.
Yes. Are MCOs expected to submit provider occurrence incidents? Are MCOs going to be submitting provider occurrences? Yes.
Yes.
And they'll go through the provider occurrence pathway in the IMS.
Yep.
And then I think this is similar to what we've talked about. If hospitalization results in a new piece of durable medical equipment or assignment of a new specialist physician, would an incident report need completed, or is an incident report only needed if there is a change to a waiver paid service?
Yeah, I don't think it's not specific to a waiver paid service. Jim is looking at that.
It just says to the service plan.
Yeah, that's general. If reportable incidents do not require an official investigation, do they need to be substantiated or unsubstantiated and have prevention plans?
And we've kind of addressed that. So no, but they do need to be verified or not, and they do need to have a resolution.
Sorry, guys, let me just keep reading these so I don't miss any. Okay, I think that's the question. Oh, missed services due to a hospital stay updated on the service plan. Would that require a report?
No.
No. If we submit a critical incident for misappropriation that involved a provider, does that automatically generate the provider occurrence, or do we do that separately?
If there's a provider occurrence that applies to that particular issue, you should choose it as well. It will be in your drop down. Is that correct, Lynn?
Yes. So if you identify a critical incident and you know who caused that, incident, then you go ahead and report both of them underneath the same case.
And so remember too, so anytime the alleged person responsible for the incident is a provider, as soon as the incident gets substantiated, the system will automatically refer over. So I think you're going to be covered in both ways.
We have a question about the timeframes for reporting.
A specific question or just?
Yeah, just what are the timeframes for reporting?
Well, okay, so just guessing at what the
I think this is
specifics.
for Medicaid.
So the responsibility for the reporter to tell the care management entity for ODM stays the same. I believe they're 24 hours, if I'm not mistaken. ODAs is different, but it's the same for ODA. And then the timeframes for the care management entity, recovery management entities to enter the incident into the IMS remains the same as today. I believe those also are 24 hours. Agings is different, but ODM is the same as it is today, 24 hours in both cases.
For a reportable incident, currently we hand off the investigation. What expectations of the case manager or CMA for obtaining an outcome?
I think we're going to go back to Jim's slide and refer to what the CM addresses or responsibilities are. So it is, again, the case manager is going to follow up with that individual, find out what happened, what are the circumstances around that particular reportable incident, and develop a plan to obviously resolve it as well as prevent it from occurring in the future.
You just kind of think of it as very similar to what it is today, just without the full formalized third-party investigation or even your own My Care Plan investigation. You're really still doing the same things in concept. You're ensuring the health and welfare. You're entering the incident into the system. You're handling it yourself instead of an investigative entity having to do a formal investigation. You are going ahead and finding out what happened, what do I need to do to fix it, what do I need to do to prevent it, and entering in your outcome. So just kind of think of it as very similar today without the bureaucratic red tape, if you will.
If a member is using illegal drugs, do we always complete an incident report?
So this is the one that was the behavior, action, or inaction, where it results in the creation of a health safety action plan or a change to a health safety action plan. We listened to people who said every time somebody uses marijuana, do we have to report an incident? And this is where we tried to narrow the focus a little bit more to get to capture that, but only really when it's a change to an existing health safety action plan or creation of a new one.
This is a good question. If a member receives a 30-day notice for eviction, is that considered an eviction incident, or does the eviction need to have occurred for it to be reported?
I would say it has to occur before it.
Well, let's go back to the incident. It says,
Eviction from place of residence. If you just get a notice that you might be evicted, if you end up getting rid of the pets and don't get evicted, then I don't think it's an incident yet. Or if it's your last notice to pay rent and you end up paying it and don't get evicted, I'm not seeing it as an eviction yet.
Okay, providers take longer to report than the hospitals do, and it sounds like it is going to a 30-day time to closure. I'm not exactly sure.
I bet you that's with the
reportable.
yeah, bet you that's here. So is it not the time of discovery of the incident? Like
Yeah, it
the
would be
case
the date
management?
of discovery would start your clock there, not the
Yeah.
date of occurrence.
Correct.
So, maybe that will help. Are we still going to continue to obtain death certificates for natural and unexplained deaths? Yeah, I mean, we don't anticipate a change to that process. When will training happen for case managers on how to enter the incident report?
So right now we're in the testing phases. So when we have concluded testing, we're going to develop a training that we're going to do. It's going to be a recording, and then we're going to send that out probably about a week prior to go live. As long as and it would accompany a guide or manual that would help help case management agencies be able to put in incidents in the system and give enough time for them to send in questions to their corresponding ODM representative with any questions that they have.
And we do plan to have some pretty significant continued outreach after the launch of this system, be hosting weekly calls and have a mailbox to receive questions. And so there will be a lot more guidance coming out over the next couple of months.
Yeah. And we will utilize the system administrators at individual agencies.
When an incident is submitted and involves a waiver agency, will the new IMS let us know who the agency is governed by, for example, ODA, ODM, or ODH? If we submit a critical, okay, so I think that's one question. And then the next question is, if we submit a critical incident for misappropriation that involved a provider, does that automatically generate the provider occurrence, or do we do that separately? So I know when you put in the misappropriation, you can select the provider as the alleged violator, and then that will shoot over.
Yeah, I think we answered this earlier.
Yeah.
It's very similar. So we definitely look at the misappropriation, and if there's a corresponding provider occurrence,
That at the time.
Right. Go ahead and select that.
If you don't know it at the time, it'll be added by the investigator.
And then the other question was, when an incident is submitted and involves a waiver agency, will the new IMS let us know who the agency is governed by, ODA, ODM, or ODH?
IMS will not do that because the person reporting should have to know, where the provider, I guess, is coming from. One of the things in the future that will not happen on Go Live is that we will be able to use the provider file to retrieve information about providers. But again, the person reporting should probably know where that provider is from, I assume.
We have a similar question. Will we continue to notify ODA, ODM, and ODH if a provider falls under those entities, all of those entities, or just one?
Right. So when you select the provider occurrences, you enter an ODM waiver provider, that's going to replace sending something separately to the mailbox at ODM that you currently do. However, for ODA, ODA is not there yet with using the IMS. So you will, when you find a provider occurrence, and you look up like you do today, whether it's an ODA or ODM provider, if it's ODA, you'll still have to use the provider mailbox that is in place today. We have explored already trying to work on a different solution to that. That might work better for you, but we're not there yet.
Who does the contributing factors for the critical incident?
The investigative entity.
And you'll get a notification when those are ready for you to incorporate.
Yeah, before they close their investigation, they will have that section completed.
How will we be able to tell if the incident report was completed appropriately if it was completed on call? So maybe I'm guessing this means, by another staff or agency.
So any incidents, and I'm going to refer back to the IMS system, any incidents that are submitted under your agency will still be viewed by everybody in the agency. So if it was submitted, the supervisor or whomever on Monday can go back and look and see if, I guess, any on-call staff submitted particular incidents. This might be a specific IMS question, and I'm not answering it correctly, so it should probably go through the IMS loop so that we can make sure we
we can look at this.
yeah,
for testing.
a little bit closer.
Who sends the letters to the members, us or ODM staff, regarding if the critical incident is substantiated or unsubstantiated?
The investigative entity.
Will substantiated critical incidents against providers still require caps, and who completes this step?
So I'm going to, correct me if I'm wrong, but so any provider occurrence that gets reported, it'll get reported into IMS, and provider oversight contractor will do what they do, and then ODM will, I think, continue to issue their nods and whatever sanctions they need to do. If it's ODA provider, you're sending it over to the ODA mailbox, and ODA will do any of their sanctioning. If I said anything wrong, let me know.
Okay. Can only the investigative agency submit extensions? Like for a time frame?
Yeah, we have the 45 days for the investigative entity in the rule. We haven't established anything yet for the reportable incidents other than we think it's going to be a 30-day time frame. But as far as asking for extensions, I don't think we've talked
I think
about
we'll
that
have to
yet.
come up with a process for that. Okay, we got, this is probably the last question we can work on, but we did get clarification for on-call. Incidents identified and completed by on-call staff, since the system directs the follow-up back to the CM or RM that submitted it, how would we, as the supervisor of the assigned case manager, know about how to follow up? Will we be able to see and edit others' incident reports after submitted? We share on-call responsibilities with our partners at another AAA.
They will be able to see it and edit to a certain extent once it is submitted. I think we need to probably take this offline and direct it through the IMS so we can give the particulars about kind of how that would look and play out. But there's ways for the supervisor to still have access to those incidents.
And if we did not get to answer your question, I do have a record of all of the questions, and we will compile all these for our document that we send out.
So we thank you all for participating in the webinar today. We will sign off now.